Good day everyone, I'm Dr. Judith Sugay and welcome to our discussion about cardiovascular disorders, particularly coronary vascular disorders. So, for the learning outcomes, at the end of this discussion, the students will be able to explain the pathophysiology of CVD, including that of coronary atherosclerosis, angina pectoris, and myocardial infarction. Be able as well to utilize the nursing process as framework for care, which includes nursing assessment, nursing diagnosis, planning of care that has, formulation or development of goal and objectives, and with the implementation, be able to describe the nursing care of patients with CVD and evaluate the outcomes of care. Okay, so we have here the coronary artery disease. This is the most prevalent type of cardiovascular disease in adults. In the Philippines, this is the leading cause of mortality. The leading cause of mortality in the Philippines is the diseases of the heart, and it's followed by the vascular systems. Okay, in the US, the most common cause of cardiovascular disease as well, on the other hand, is the coronary atherosclerosis. Okay, so having said that, with the coronary atherosclerosis, this is an abnormal accumulation of lipid or fatty substances and fibrous tissue in the lining of the arterial blood vessel wall. So, what you can see here is a normal human artery. Okay, so the substances, these substances, the lipid or fatty substances and fibrous tissue in the lining, okay, cannot be seen here in the normal artery. Okay, so this one, all right, they are reducing the blood flow to the myocardium. So atherosclerosis involves repetitious inflammatory response to injury of the arterial wall and subsequent alteration in the structural and biochemical properties of the arterial wall. So, see, compare this one to the normal artery, which is clear and has no obstruction. Okay, what happens when there is inflammation? Okay, so the inflammatory response is the one involved in the development of atherosclerotic, okay, which begins with the injury to the vascular endothelium. Okay, so here, this is the lining, okay, and this will progress over the years. So the injury, inflammation may be caused by several factors. It could be due to smoking or tobacco use, hypertension, increased cholesterol, or hyperlipidemia, and other factors. So the endothelium undergoes changes and will stop producing normal antithrombotic and vasodilating agents. So with this one, okay, the presence of inflammation attracts inflammatory cells like macrophages, which will now ingest lipids, becoming foam cells. Okay, so we have here. So there will be fatty streaks, foam cells, again, that transport the lipids into the arterial wall. And then some of the lipids is deposited on the arterial wall and forming fatty streaks. Okay, we've mentioned that one. So, activated macrophages, we've mentioned a while ago, also releases biochemical substances that can further damage the endothelium by contributing to the oxidation of the LDL, okay, which we call that before as the bad cholesterol, right? So, this is toxic to the endothelial cells and fuels progression of the atherosclerotic process. So, following is now the transport. Okay, so the transport of lipids into the arterial wall. Okay, smooth muscle cells then proliferate and then form a fibrous cup over a core. Okay, so this one you can already see. Okay, and then it's filled with lipids, okay, and inflammatory infiltrate, and we refer to that as atheroma or atheromas. So again, atheroma is a plaque. It protrudes into the flow. It blocks the flow. Okay? So, what happens next is that thick plaque and lipid pool remains relatively stable. Okay, so with that one, it can resist the stress of the blood flow to the vessel movement. Okay, so if the cap is thin already and there is continuous inflammation, okay, the lesion becomes vulnerable to plaque. The lipid core, this is the lipid core, okay, may grow, causing the fibrous plaque to rupture. So if now it becomes ruptured, okay, so what do you think will happen? A ruptured plaque attracts platelets and causes thrombus. Okay, so there'll be block. It's going to block now the artery or the blood vessels. Okay, so there'll be thrombus formation. Okay, which may then obstruct the blood flow, leading to the acute coronary syndrome, which may result to heart attack or myocardial infarction. So when MI happens, portion of the heart muscles no longer receives blood flow and becomes necrotic. Okay. So, what are the risk factors of developing coronary artery disease? We group them according to its modifiability. It is non-modifiable if, again, we pertain to age, gender, genetic factors. There's nothing we can do about this one. But at least we have to find out more about it so we can prevent and provide health teaching to our clients, right? So, for the age, coronary artery disease is common among individuals after 40 years old. Okay, so it's particularly common among men. Okay, and again, it is because women are protected by HDL after menopause. So, however, they are now more predisposed, okay, when there's decrease in estrogen. Remember? Okay, so another one is genetic factors. Okay, so genetic or familial factors seem to have really a strong influence, okay, on serum lipid levels, metabolism, and cell receptors for lipids. Okay, so can we still modify, or are there really modifiable risk factors? Meaning, we can change, or the client can change, given the chance, given the knowledge, okay, given a health teaching about it. So, let's find out about that one. In terms of modifiable risk factors, we have obesity. Okay, so obesity or diets high in cholesterol and animal fat, again, elevates serum lipid levels, especially that of LDL. Ang hirap na magsulat dito. Okay, LDL. Okay, which is the bad cholesterol. Okay, so another one is cigarette smoking. That will also increase the low density lipoprotein. How about those who do not love to get engaged into activities, do exercise or physical exertion, okay? Then also they are going to be at risk. And those with uncontrolled diabetes and hypertension. Again, there's nothing we can do anymore if they are diagnosed with diabetes and hypertension, but they must follow the prescribed medications, treatment of their physicians. Otherwise, they are really prone into developing coronary artery disease. Okay, so there. Again, poorly controlled hypertension causes endothelial damage. And other factors here, we have intake of oral contraceptives as well. Okay. For the diagnostic test, we have taking serum lipid levels. Okay, so to check if the cholesterol level is within normal range, to check as well if there's high LDL compared to HDL, HDL again is the good cholesterol. Okay, so we want normal range and we don't want this LDL to be increased. Okay, so there's also serum levels of high sensitivity C-reactive protein. Okay, so this will indicate the presence of any inflammation. So this will indicate the risk. So again, it's going to be easier to focus on the diagnosis if this is done. Okay, stress test. So to assess the degree of obstruction in the arteries, so this will be conducted. Okay, we have mentioned before how stress test is being conducted. Okay. Another one is the radio isotopic studies, which determine the degree of tissue perfusion and the presence of collateral circulation and its degree of local cell metabolism. Okay, then what can we do about this one as nurses? Okay, so in terms of nutrition, we advise our patients to take food low in saturated fats, so more on fiber and less animal fat. Okay, so this will slow down the progress of atherosclerosis. So also minimize the intake of sodium to control hypertension and of course manage hypertension as well. And let's add diabetes mellitus if it is present. Advise the client to cease smoking. Offer what? Variety or alternative activities that will enable the client to cease smoking. And then advise the client to adhere to medication regimen. Okay, so there are several drugs that could decrease or normalize one's lipids. So lipid reducing, we have the Probicol, clofibrate, okay, lovastatin. This should be prescribed by the cardiologist. Okay, in terms of thrombus formation, okay, if found, then also the physician will prescribe antithrombic medication such as or anticoagulant, okay, like that of aspirin or ASA or warfarin or that's Coumadin. Okay, so you're still with me. Okay, then if really this condition progresses, then surgical treatment will be done. So we have the PTCA or the percutaneous transluminal coronary angioplasty. So we have mentioned prior also part of the diagnostics that this will include, okay, and this is a procedure, okay, which involves a catheter. Okay, so a catheter contains an inflatable balloon. Okay, so this one is the catheter. It contains the inflatable balloon. Okay, if this is the artery, all right, and it will flatten the atheroma. Okay, this is the atheroma. Okay, so it will be guided by the catheter. Okay, so there's an inflatable balloon. Another one is the laser angioplasty. A laser beam, okay, this is advanced already. Okay, so that's very good of our technology. It okay, it's more of advancement, innovation. Okay, so laser angioplasty is a laser beam and fiber optic technology with catheter. Okay, so the high energy laser causes the obstruction to disintegrate into microscopic particles that are removed by macrophages. Okay, so this is done. Okay, this is the traditional. Okay. Okay, another one, have you heard of this one? CABG. Okay, so coronary artery bypass graft, that's CABG. This reroutes blood flow around the obstruction. Okay, so this is the obstruction, this is the blocked artery, there. Okay, it will now reroute. Okay, so again, it will use the the use of veins of either left internal mammary artery for graft. So they will get a healthy vein so they can reroute. If here's the blocked, okay, if this is the blocked artery, then having the cabbage or coronary artery bypass, this now happens. See? Okay, there's rerouting. So can you see the new one? Okay, so there. So however, this is an intensive procedure. You really have to provide health teaching. You really have to explain to the client the things for preparation, what to expect, and so many more. So, post-operatively, okay, the nurse should monitor the signs of complication, such as of infection, okay, so there should be constant monitoring of vital signs. Also check if there's bleeding, okay, because of this procedure. And then check as well if the client has no difficulty of breathing. Are there blood clots? These will be shown, of course, also by conducting some tests, okay? And then brain damage, okay, that we do not want. So again, you are to administer medication as prescribed by the doctor. So antithrombolytic, anticoagulant, so that's what's going to be given, okay? Okay, any questions about that? Moving on, we have hypertension. So, any of you already have hypertension? So, what happens when there's hypertension? So, in hypertension, a systolic blood pressure measurement of greater than 130 millimeters mercury, or diastolic BP, which is greater than 80 millimeters, okay, mercury. So, there. Whenever you diagnose, it's not enough to say that, for example, your blood pressure was taken and then just for now, you've seen that it's 130 or 140 over 90. Okay, so it's not right away going to be concluded that you have hypertension. So it takes averaging 2 to 3 readings of different occasions in order for you to have an accurate measurement. So what happens if there's long-standing elevated blood pressure? Okay, so with that, there will be increased stiffness of the vessel walls, so leading to vessel injury and resulting to inflammatory response within the intima. So remember the formation of the atherosclerosis, that again, it's a result of an inflammation, an injury. So one is this hypertension. So inflammatory response or mediators again will lead to the release of growth, promoting factors that causes the vessel to hypertrophy and hyperresponsiveness. So there'll be, mangangapal na yung wall. Okay, so these changes, ayan, okay, so given this hypertrophy and hyperresponsiveness, what do you think will happen? Okay, the atherosclerosis will get worse. So if we have this one, okay, as the artery, okay, having this, okay, before, but then there's already hypertrophy, then there will be more reduced blood flow to the myocardium. Okay, and then next is that these changes result in acceleration again of the atherosclerosis. So meanwhile, there'll be compensation. There'll be increase in the work of the left ventricle. The left ventricle will compensate, will pump harder to eject blood into the arteries. So over time, the increased workload causes the heart to enlarge. Okay, so there is again hypertrophy, and then it will result to heart failure. So what's the take here? when doing health teachings, it's very important that you emphasize the need to consult the doctor should there be any symptoms, okay, or any findings, of course, that happens, or any manifestations, okay. There should be consultation with the physician. So let's describe now the angina pectoris. Okay, so angina pectoris is a clinical syndrome usually characterized by episodes of pain. Okay, there are times that there's what? Pain or pressure in the anterior chest. Okay, so it's in the anterior chest. It's caused by reduced blood flow. So, having a decreased oxygen supply, okay, when there is increased myocardial demand. So, just imagine there is reduced blood flow, but the myocardium needs more. Okay, so there'll be physical exertion, okay, and then it can also result to emotional stress, okay. So that's what's happening when there's angina pectoris. Okay, so there are several types of angina. We call it stable, unstable, intractable, variant, and silent. Let's have the stable. A stable angina is predictable and consistent pain. Pain on like exertion, like for example, just walking, okay, and then it can be relieved by rest or by taking prescribed medication, nitroglycerin, okay, so it can be relieved. And then contrary to unstable. The unstable, the symptoms increase in frequency and it varies with severity. Okay, and then even if the client takes rest, it's still there. Even if the client takes nitroglycerin, it's still there, the pain. So, another one is the intractable. So, this one, it's severe incapacitating chest pain. So, it's severe. It's not tolerable, okay? Another one, we have variant, okay? So, here the client experiences pain, chest pain at rest with reversible ST segment elevation. So, there is vasospasm. Again, ECG was already determined by, of course, prior to saying that it's really caused by, or it's a variant type. We have the silent ischemia. Okay, so objective evidence of ischemia such as ECG changes, not normal stress test. Okay, so there's already evident findings. Okay, it's objectively speaking, there is really ischemia, reduced blood flow. However, the patient says, I don't feel any chest pain. I don't have any pain. Okay, there. So, what do we really see among patients with angina pectoris? Okay, chest pain. So, chest pain, here there's ischemia of the heart muscles. Okay, the ischemia of the heart muscles may produce pain from mild indigestion to a choking or heavy sensation in the upper chest. So, some of the people having said that it's like, you know, there's mild indigestion, they say, parang hindi ako natunawan, parang there's something weird but tolerable. Okay, so at times, may ganun pa sa simula. So that's the chest pain. So again, because of ischemia. So, next, we have the radiating pain. So, the pain is poorly localized. It's radiating, okay? Poorly localized and may radiate to the neck, jaw, shoulders, and inner aspects of the upper arms, usually the left arm. So, here, the patient will say, masakit yung likod ko, parang sumasakit, ganito, yung sa batok ko dito, and yung pakiramdam ko parang nangangawit ako, nangangalay ako. So, there, you can associate it. You have to really double check other symptoms and check the blood pressure. So, do some interventions. Another one is weakness and numbness. So, here, the client will say, I'm starting to not feel anything in my arms, wrist, and hands. Okay, so it's like it's getting numb. Parang wala akong maramdaman or nanghihina. Okay, and then there's shortness of breathing. Then you can see the client turns pale. Okay, what else? Pinagpapawisan, diaphoresis, medyo nahihilo, dizziness, and there is this feeling of, unstable surrounding. So there's lightheadedness, okay. And some others, of course, will also say that they feel nauseated, and then some would vomit, okay, as they really feel the pain. Okay, so what are the usual medications for this one? So we have nitroglycerin. So it is a potent vasodilator. Okay, having a vasodilator, of course, with this one, for example, this is the artery with having this one, okay, and having this plaque, okay. Given the vasodilator, it will improve the blood flow. Okay, it will improve the blood flow to the myocardium, and it will relieve pain. So, beta-adrenergic blocking agents, so they will reduce the occurrence of MI or myocardial oxygen by blocking beta-adrenergic sympathetic stimulation to the heart. So, having said that, expect that the heart rate will decrease, okay, because this is increased at the onset. So, blood pressure also decreases, conduction system, and the myocardial contractility improves there. Yeah. Okay. So, next we have calcium channel blocking agents. So we have intake of amlodipine. Okay, so this one decreases the SA node automaticity and the AV node conduction. So it will result to slower heart rate, okay, and strength myocardial contraction. We've mentioned before as well, on the other hand, we have antiplatelet and anticoagulant. These are blood thinners because you don't want any thrombus formation. So, if given the platelet aggregation and subsequent thrombus, it will impede the blood flow to through the coronary arteries. That's why, again, what are the usual medications? Example of this one. Okay, you have ASA, you have warfarin. Okay, so in some instances, the doctor will prescribe some H2 blockers or proton pump inhibitors. Those are called like omeprazole, okay, because of GI or gastrointestinal tract irritation. So, if that keeps on happening, it will result to GI upset and bleeding, because that's the side effect of this antiplatelet and anticoagulant. Okay. Okay, so heparin prevents anticoagulation, okay, and fraction 4, heparin prevents the formation of new blood clots. So, again, it will treat the patients with unstable angina. So, commonly also, we also have this one, the glycoprotein 2 and 3A, to be 3A agents. So, this administration through IV, okay, indicates again, it is indicated again for patients with unstable angina. So, what does it do? It prevents platelet aggregation. What else? It prevents adhesion of fibrogen and other factors that cross-link platelets to each other. Because if it happens, that will form coronary clots. Okay, so moving on, let's now have the nursing process. So you're done with your assessment, and then for the nursing diagnosis, we can actually have like any of these. Remember, whenever you do your your nursing diagnosis, there must be evident cues based on your assessment. Okay, so there could be risk for impaired cardiac output. Okay, so anxiety associated with cardiac symptoms and possible death. Could be lack of knowledge about underlying disease, inability to perform self-care because of restrictions to movements. Okay. This now is going to be one of the nursing goals. Prevent angina, okay, reduce anxiety. So the client will have awareness on the disease process, and that the client will be able to adhere to self-care program. Okay, for the nursing interventions, since there's anxiety, okay, again, address the emotion, right? So we can advise various stress reduction. It could be like guided imagery. You can teach your client or your patient to do some meditation, okay, and then teach how to practice guided imagery, music therapy. You can read on journals on how to conduct this one. Provide alternative activities as to balance with rest periods, and then take some small or give small demonstration of simple self-care. So self-care cannot only help the patient improve their condition, but this will increase their confidence. So it's very important that we show them that we really trust them in a way that they can really take care of themselves slowly. Okay. So for the evaluation, again, we look forward that the patient reports that pain is relieved promptly, okay, anxiety is reduced, that they understand ways to avoid complications, and then they also adhere to self-care programs. Okay, let's now have the discussion about myocardial infarction. So this time we now have the ACS. Again, so this is, again, you know that this is an artery, right? What is really myocardial infarction? So plaque rupture, okay, there's a plaque rupture or there's vasospasm. So when that happens, okay, there will be a narrowing of the coronary artery. If there is plaque rupture here, take a look, okay. So if there's plaque rupture here, then what will happen again to the blood flow? Will it increase or decrease? Okay, it will decrease the oxygen supply because of blood loss, low blood pressure, or increased demand, right, for oxygen and other which causes this one. Okay, so there will be imbalanced oxygen supply and demand. So the area of infarction develops over minutes to hours as the cells are deprived of oxygen. So with that, there's going to be ischemia. There's reduction of blood flow. Okay, and then what will happen again? There will be cellular. Okay, after the inflammation, there will be cellular injury. Okay, and then the lack of oxygen results in infarction or death of cells because it hardly reached the myocardium, right? So, subsequent thrombus formation results in complete occlusion of the artery leading to, again, ischemia. Okay, so there will be myocardial infarction, and then what did we mention a while ago? That this can also lead to necrosis of the myocardium, right? Okay. So what happens when there is myocardial infarction? Again, in terms of cardiovascular, there's chest pain. It occurs suddenly and continues despite rest and medication. Expect the blood pressure to increase. Okay, and then also check unusual fatigue, sleep disturbance. Okay. There's also a combination of chest pain, shortness of breathing, okay, indigestion, nausea, and anxiety. Okay, all of this, it could be a combination. So, again, in terms of respiratory, there might be what? So, there's dyspnea, difficulty of breathing, shortness of breathing, tachypnea, okay, increased in respiratory rate, with effort, okay, to breathe. And then for the gastrointestinal, there's nausea, vomiting, indigestion. Okay. So, genitourinary, there is what? Decrease in urinary output, meaning there's already there's beginning cardiogenic shock. The skin, cool, clammy, diaphoretic, pale. For neurologic, okay, when you interview the client seems to be apprehensive. There's anxiety, lightheadedness, okay. So, it again with that, there's decreasing in the contractility and cerebral oxygen. Also, when you talk to the client, some of the clients will mention that they have, they have this feeling of fear, but they have this thinking that it's not true, it's not happening. So there is denial. Okay. Let's now assess. Okay, so for this one, there's a need for the conduct of electrocardiogram or ECG. A 12-lead ECG must be obtained within 10 minutes from the time that the patient reports pain. Okay, and then what else? Of course, this must be done with the doctor's order. So, as soon as the patient arrives in the emergency department, this must be done. So, in doing the echocardiogram, okay, it's used to evaluate the ventricular function. It could detect hypokinetic, kinetic wall motion. Okay. Lab tests, we have the troponin test, this one, the CK and its isoenzyme, let's see later, and then the myoglobin. Okay, so we'll discuss that. So, what could be the effects of ischemia or the reduced blood flow to different parts of the body, also, of course, to the myocardium. So, again, ischemia is a condition in which there is a restricted or reduced blood flow, right? Cardiac ischemia is the name if there is decreased in blood flow and oxygen to the heart muscle, which is the myocardium. So, we have mentioned here, excuse me, expected ECG changes. We have the T-wave. T-wave inversion, ST segment elevation. We also have the development of abnormal Q-wave. So, ischemia causes inversion of this one. And then, myocardial, Q-wave develops because of the absence of depolarization or the squeezing of the heart. And then, it is because of the necrotic tissue and opposing currents from other parts of the heart. So, this is now, okay. So, there. Okay. Laboratory findings, we have mentioned this a while ago. We have the troponin. So, it is a protein found in myocardial cells. This regulates the myocardial contractile process. So, we also have the creatinine kinase and its isoenzyme. Okay, so this one, ZK isoenzymes, these are biomarkers. They are very important. Okay, take note, the CIT. Okay, So for the CK isoenzymes, it actually have several focus. Like CKMM is for the skeletal muscle, CKMB for the heart muscle, and then for the brain tissue, you have the CKBB. Okay, increase in the CKMB, so that is the heart muscle, right? Okay, having an elevated CKMB indicates acute MI. And the level begins to increase within few hours and peaks within 24 hours of an infarct. So, on the other hand, myoglobin is a heme protein that helps transport oxygen. Okay, so just imagine having a low myoglobin. So, this is found in cardiac and skeletal muscles. So, it starts to increase within 1 to 3 hours and peaks within 12 hours after the onset of symptoms. Okay, you'll find this like familiar with this, as we have mentioned a while ago. We have the PTCA, okay, insertion of a balloon tipped catheter. Again, this will look it actually what flattens. Okay, if that happens, then there'll be what broader lumen. Okay, and then coronary artery stent, the process which includes mediators that leads to vasoconstriction and scar tissue formation. So a stent is a metal. Do I have it here? Okay. Okay. So a stent is a metal mediator. Okay, it provides structural support to a vessel at risk of acute closure. Okay, another one, of course, we mentioned this CABG, coronary artery bypass. So there's elevation of angina that cannot be controlled with medication of PCI. So there's treatment for left main coronary artery stenosis, or if and when, so CABG is being done if there's already several blocks, like, you know, it's not only, let's see, it's not only here. It's, for example, this one, there are really tiny vessels here, and okay, so if you're going to say that stent can be done, okay, unfortunately it cannot, because it cannot resolve the problem, because still you will not, the patient will not receive the oxygenated, I mean, there's going to be less or no relief at all, or not useful, because it cannot reach other necrotic cells. Therefore, so what has to be done? So they leave it that way, and then they just reroute there. They just do something, and then again, this bypass graft will now, this artery will now be connected to major arteries to be able to, for the blood or oxygenated blood to reach or be transported to the myocardium. Okay. So, very important. Okay. Patient showing those symptoms, immediately, again, bring the client to the hospital. And then, in the emergency department, they will obtain this 12-lead ECG for interpretation within 10 minutes after, 10 minutes upon arrival in the ED. Okay, and then obtain laboratory specimen, the CIT, the isotonic enzymes, okay, and then what else? There are also obtain other diagnostics. So begin with supplemental oxygen, okay, O2, provide O2, what else? Nitroglycerin, morphine. Again, this one, they must be prescribed by the attending physician, okay? And as nurses, we must be careful of what we carry out, okay? And then, evaluate if ever there is reperfusion therapy, evaluate its effectiveness. Check if there's any adverse reaction. And then, again, continue to carry out prescribed medications, okay? There should be bed rest for a minimum of 12 to 24 hours, okay, for the PCI. Alright, so the student nurse is now ready to conduct assessment. So remember a while ago, the signs and symptoms, right? So you go back to that, you can review that one so that you'll be able to initiate or ask questions related or relevant to the signs and symptoms. Make sure that when you ask, it's not something that's going to be, leading. You must ask in a way that you are really trying to probe, you are really finding what happened, and how is the client doing. Okay. For the nursing diagnosis and goals, okay, we have acute pain associated with increased myocardial oxygen demand. However, there's decreased myocardial oxygen supply. So, what's your goal here? To relieve pain. So, the client will be relieved of pain or ischemic signs as evidenced by improved condition, less reports of pain, and so many more. So, another one is impaired peripheral tissue perfusion associated with impaired cardiac events and possible death. So, of course, after nursing intervention here, the client will be able to maintain adequate tissue perfusion. Another one is risk for impaired cardiac function associated with reduced coronary blood flow. So, because it's still a risk, it's not yet evident, it's not yet happening, then what's important is that you will be able to inform or increase the awareness of your client about early recognition of complications. So, for nursing interventions, these are just some of the nursing interventions. Again, balance oxygen supply with demand as evidenced by relief of change in feeling of pain. Okay, so having said this one, you have to monitor the vital signs. You also have to monitor the fluid volume status to prevent fluid overload, because again, if having fluid overload, that will make the client be more susceptible to what difficulty in breathing, alright, and some complications. So when you also encourage physical rest, you make sure that the head of the bed is elevated so that there will be ease in chest discomfort. Okay, and then alleviate anxiety and decrease fear by interventions like providing or teaching the client how to do meditation, guided imagery, music therapy, and the like. Okay, so of course, for the evaluation, we look forward that the patient now experiences relief of angina, has stable cardiac and respiratory status, maintains adequate tissue perfusion, exhibits some decreased anxiety, that the client adheres to self-care program, and has no complications. Alright, there you go. These were the references that I have used. Okay, you can also, read other references if you like. And then, there. If you have any questions, please let me know in our meeting. And again, I hope that you're able to learn something today as you've listened to this lecture, as you've read the slides. So, thank you. Thank you everyone. Maraming salamat.